Thank you very much, Dost. I think you are with whom we should be proud of as Turkey, and hopefully in 5-10 years you're going to bring Nobel Prize to Turkey. No, maybe Golden Bear or Golden Orange would be more likely. We have 1.5 hours, and so I'd like to finish earlier before you go into hypoglycemia, and then the rest of the details we can talk during lunch break. So whenever I deliver this lecture, I get depressed, and so these slides I'm going to show from 30 to 45 minutes. This work took 25 years of time. It's difficult to explain all of that in 15 minutes, and it shows how bitter life is. I mean, you have to fit it in 15-20 minutes, but still we enjoy to do this research. So first, let's start with sodium nitropurisside story. Before telling that story, let me say, in 1995, I was in Halifax, Dalhousie University. I was working there with a team. Back then, we guessed that the people who discovered nitric oxide were about to receive Nobel Prize. So we thought, we wondered whether Viagra would work on the brain as it works in almost everywhere else. So we wondered if we could come up with a Viagra for the brain. Nitric oxide is a very peculiar molecule. It doesn't act by itself. It's diffused all around the brain, going through all neurons. Let me show you its effect. So before starting, I'm going to go into physiology, and then we will proceed with the pathophysiology and the neurology of it. Under normal conditions, this glutamate receptor does not act by itself. As Dr. Taminga also showed, this is a very important molecule. It connects the NMDA glutamate receptor to the nitric oxide system. So when it sits on the glutamate binding sites, it activates the receptor. In this activation, calcium plays an important role because it activates the receptor binding to calmodulin, and it activates nitric oxide, and its precursor is L-arginine. Well, L-arginine is sold in pharmacies. You know, bodybuilders use it, and they say it's miraculous. They call it herbal Viagra. So L-arginine is converted into neuronal nitric oxide, and in this mechanism, if the patients, or in animal studies, there are 3 main NMDA receptor antagonists, one of which is phencyclidine, the other one is ketamine, the other one is MK801, the NMDA receptor antagonist. While we only use ketamine in the clinic as an anesthetic, and pediatric urologists use it in Canada when it comes to circumcision. Well, in the past they used to give us Turkish delights. Now they give ketamine because we're more civilized, obviously. So phencyclidine is stronger, but MK021 is more potent. They all have different characteristics. Some act on the dopamine, serotonin, GABAamine, but their common character is an NMDA antagonist. So they conduct an experiment. When they design the experiment concept. They make a rational choice. So they ask, why did you choose ketamine or phencyclidine or MK-081? Therefore, I think it's inappropriate to do any experiment without first understanding these three molecules. So, in order to work on nitric oxide, activate nitric oxide, we chose phencyclidine. Why? Because we were looking for a schizophrenia model. But of course, animals don't get schizophrenia. But ketamine was used as an NMDA receptor analysis antagonist in the literature. But it shows some dissociative symptoms. Even antidepressant, you don't see the negative symptoms. You get euphoric, but that is also a full NMDA receptor antagonist. The MK-8 causes delirium. So we placed them under the microscope, studied them in order to choose correctly, and we decided upon using phencyclidine. So if we are to do glutamate schizophrenia animal study, phencyclidine is the best. That was what we said back then. Why? Because phencyclidine can be used illegally by everyone. They call it angel dust. You think yourself as an angel when you use it. What happens? I've seen in the ER acute and chronic users of phencyclidine. They might present with catatony, withdrawn, no speech. So you see a picture that's similar to negative features, positive and negative features of negative schizophrenia. But we don't see the entire picture, of course. Also, in users of angel dust, there is typically a cognitive deficit. That's why, based on human data, this is the closest picture to schizophrenia. That's why we chose phencyclidine. What do we see in the preclinical experiments? When you administer single dose phencyclidine, you see an outlook which is similar to schizophrenia. We see hyperlocomotion and also stereotyped behaviors. That's what we exactly saw, the stereotyped behaviors observed in animals. So this is quite parallel to schizophrenic behavior. Let me show you this. Faizi would know better than me, of course, but let me still repeat. The first principle of pharmacology is you do a dose-response curve. You start with saline, and then we started with as much as 50 milligram per kilogram. And I will not tell you what happened to the animals at this stage. It would not be very pleasant. So we place the animals in the automatic apparatus, and we track the animals with the GPS, and this is how we can track the animal with 5 milligram per kilogram. There is significant hyperlocomotor activity. And back then, when we did these experiments, we noted down the stereotype behavior, because there are apparatus which can measure stereotype behavior. Back then, it was not this sensitive. In 10 milligram, this hyperlocomotor activity was less, and in 50 milligram, there was some picture like delirium. In 25 it looked like ataxia, and then in 50, so we checked the dose response, and in principle we chose which one? 5 milligram per kilogram. We chose 5 milligram per kilogram based on this data. we checked the literature. Some people use 2.5 milligram per kilogram, and they say maybe at 5 milligrams this is how the mouse will look. So the results from different experiments may be different, that's why. So after doing these experiments, we did this analysis called CFOS. This is force-like immunoreactivity. You administer phencyclidine, for instance, and then we took the brains of the animals, we cross-sectioned them, we checked the force-like immunoreactivity. This shows neuronal activity, quite sensitive. In which parts of the brain there is neuronal activity. We checked it, and it turns out the areas of the brain that we found, of course we checked only those areas in the human brain which are affected by schizophrenia. For example, in the thalamus it's very high. It's also high in the hypothalamus and also in frontal cortex. In the anterior cingulate it was high, but not that high. In the basal ganglia, in the putamen nucleus, it was not statistically significant. This was very encouraging for us. We thought the phencyclidine indeed is very close to a schizophrenia outlook in humans, and that's why we proceeded with our study. Well, after starting, we worked for 25 years, and we said we should use the antisense technology. What is antisense technology? It's a protein. It's a selective protein, to be specific. When you administer it, it just blocks the nNOS. Our hypothesis was this: if we selectively administer nNOS antisense to the patients, if this is right, if we block it with antisense, then the schizophrenia picture must be blocked with phencyclidine. What is the advantage of antisense? It has no side effects and also won't affect neurodevelopment. So we don't administer it for a long time to the animals. So what were our experiment results? Indeed, when we administered antisense, it blocked phencyclidine. It brought down hyperlocomotor activity, it slowed down the animals, and reduced stereotyped behavior. Why did I write in blue no ataxia? Because when you see ataxia, it is a toxic outlook, delirium. We did not see this in the patients, and that was very pleasant for us. So it's a good hypothetical start. We thought neuronal nitric oxides is blocking the outlook characterized with hyperlocomotor activity and stereotyped behavior, which is associated with PCP. And we used the knockout mouse model, and we examined the effect of phencyclidine in mice deficient in neuronal nitric oxide synthase. It's slightly expensive, but it's good for the experiments. Then negative means mice where nNOS is not found. So we said if nNOS is not present, we will not see the effect of PCP. So what are the advantages and disadvantages? The disadvantages is that when you pick any knockout mouse, it might affect its neuronal development because this gene is missing neonatally. In that case, the development may be affected. And the advantage is this: when you pharmacologically administer these drugs, you don't see any side effects. And we did these experiments with controls, and when we did them, it did not stop the hyperlocomotor activity, it did not reduce the speed, we did not see any behavioral changes, but we saw blocking of neuronal activity in CFOS expression level. So we concluded NOS is essential for PCP-induced processes. And then principally we thought we should use pharmacological drugs. First of all, we checked the neuronal nitric oxide inhibitors. We asked ourselves, what happens whether we administer these inhibitors? This is L-name, an inhibitor. It increased the PCP effects. All animals became more agitated with increased hyperlocomotor activity, and we also observed that at the molecular level, and there was an increase in CFOS expression. We demonstrated all that, we published it as well. And then, since we're looking for a treatment, we wanted to try the opposite in order to treat. So if the inhibitor is doing this, what would the nitric oxide donor do? And we decided to use sodium nitropurisside. It is an NO donor, very potent. It's used in the clinic. It's used in malignant hypertension, for example. The patient is presenting to ER. Blood pressure is like 200 to 125. Has 2 minutes, and they quickly administer sodium nitropurisside. I saw it only once, maybe, because they had maybe only 3 minutes to lower the readings of the patients. The more old school cardiologists were using it because this was burdensome. They keep it in aluminum foil because if it sees light, it's inactivated. So you had to bring it in darkness, and you had to administer it in darkness. And we saw that it blocked all the behavioral and molecular effects of PCP. It blocked the CFOS. Now it took 10-15 years of hours, and then we asked what could be done in the clinic. So we did a joint study with the Brazilian colleagues. We did this study in 2013, which took a long time. When we did it, we asked everyone about the ideal dose in order not to harm first, and so 0.5 microgram per kilogram per minute was the dose we chose. Anestheticians, they said this is very low, or maybe they said the duration is long. So we said we should maybe do it first as a proof of concept, and then maybe we are going to do those response studies. So we carried out this, and single dose we administered intravenously, and when we did that, there was anesthesiologists by the bedside. There was a cardiologist available, 2 psychiatrists were available, and I'm now going to talk about design. This is very important. Which patients are to be included? So you are administering a drug which you can give to malignant depression. So we wanted young students, and we had only one center. We studied the first 5 years of the disease. Why did we choose these patients? Why those in the first 5 years of the early stages of the disease? Because schizophrenia is a very complicated disease, and probably you've seen this before. The patients we included are here in the pink part. They go beyond the prodromal, and the outlook we see here is glutamate psychosis. So it is already a known thing. In the earlier stages of the disease, glutamate increases, and after glutamate increases, it goes into progressive stage, and the neurochemical outlook here is much different from the neurochemical outlook here. And that's why we chose this part. And looking at the mechanism, we were focusing more on the glutamate psychosis, not the dopamine psychosis. That's why we needed to focus on the patients in this stage of the disease, because the citrum is going to go into atrophy, and even dopamine and other heterogeneous chemical outlook develops. And I'm going to show it to you developmentally. And these blue areas that you see is neurodegeneration. Well, schizophrenia is not like Alzheimer's, but it has its own peculiar neurodegeneration outlook. That's why we wanted to choose this part. So we deliberately chose this part. Let me also show this one. Let me show it in a different way so that we can have a good understanding of it. So at the earlier ages, this shows age as well. Typically glutamate and also the COMT gene is activated. Dopamine dysregulation starts afterward. Typically it starts with glutamate, and then dopamine and the other systems become abnormal. Let me show this once again. This is a chronic schizophrenia outlook, and once it starts in the earlier stages at the disconnectivity levels, this glutamate, NMDA and GABA start first, and then it goes toward others. That's why we chose the earlier stage. Since this was proof of concept, since we are doing translational research for phencyclidine, so we needed to take the first 5 years. Maybe we should have taken even the first 2 years stage. Well, glutamate is it the responsible neurochemical substance in the onset of schizophrenia. So the lines you see on the right shows that glutamate is indeed hyperactivated in the earlier stages, especially in limbic areas. So this is a classical finding which is seen in meta-analysis. So schizophrenia is such a complicated disease that almost like cancer. I mean, when you talk with the oncologist, the first thing they say is stage 1, stage 2, stage 3, stage 4. When it comes to schizophrenia, we cannot talk about something like that, and maybe that has to change. Maybe we need to have some kind of staging system, which would require big data, and we have started doing that. So, how did we measure these patients? We used a brief psychiatric rating scale. We had separate interviews, and the BPRS is classically used in hospitalized patients, and also PANSS scale is used. So I did this, and I went to Brazil as well. Let me show you. Mean onset is 25 years of age for our study. Number of hospitalizations 1.5. So Length of illness, duration of illness, 34 weeks. So it's almost like 1.5 years. Young patients, so they came with a glutamate psychosis. So all of the patients were receiving drugs. They were not antipsychotic naive, and we did not change their treatment. So this was also randomized. Let me show the results. And this one is a protocol for our study. They come and 48-hour period with no medication change, and then anesthetists and the cardiothoracic surgeon present to ensure safety during each infusion. Patients and frontline staff involved were blind to the assigned infusion, so BPRS and pulse negative, and we do this. So the data we found was really very important. That's why sodium nitropurisside. And I talked to the anesthetist that the patients usually presented in a state of catatony, and I know nothing would happen to the group receiving placebo. But in the group which received sodium nitropurisside, they were more active, they were more lively, they would start talking with us, and they would join their families to go down to the cafeteria. And the only thing we did not do, which we regret, is maybe we should have filmed these patients coming, maybe using a double-blind approach. Maybe if we do this study again, we will do that. And I talked about negative symptoms. Those patients who came, they had severe negative symptoms, and they improved significantly after administering sodium nitropurisside. And unfortunately, we could not see any side effects. This is about our sensitivity of our study. Maybe blood pressure slightly decreased, but other than that, we did not see it. So this was a good start, and after that, we closely followed the literature. We wanted to do this in Canada. They said $10 million if this study was to be done in Canada. The Canadian government said sodium nitropurisside needs to be administered in intensive care units. We can't give you regular psychiatrists. And $25,000 is the cost of one night in ICU, 2 nurses, so it's very costly, so we could not do the other studies, but we waited for the literature. So we were following up the literature on this. So in 2018, Jonkman et al. From Leiden University in Netherlands, who were anesthetists, they did a randomized double-blind placebo-controlled crossover study in healthy volunteers, not ill people. They checked proof of concept, and since they were doing human trial, they can't use phencyclidine or MK-01. They use ketamine, and ketamine has 2 generic versions. One is racemic RS ketamine, which I will talk about in the second part of my speech, and the other one was S-ketamine, which is purer. And the S-ketamine is like antidepressant dose, 70 milligram. So they applied it, randomized, double-blind. It's a placebo-controlled trial. They also administered intravenous sodium nitropurisside and single dose. What did they find? Well, did they give the data which we had already found in healthy subjects? Well, they did, yes. They were checking psychedelic side effects because they were anesthetics. They were checking things like dissociative findings. So the dissociative, or as they call it, psychedelic side effects were blocked by sodium nitropurisside. This is what they found. But the psychedelic symptoms caused by S-ketamine are not blocked by sodium nitropurisside. So what is the difference? Why did it block the symptoms from racemic ketamine and not block the symptoms from S-ketamine? So racemic ketamine is diluted. It's almost half dose. This one is more potent. It goes faster to the brain, and if instead of 0.5 microgram kilogram, if they had administered 1 milligram per kilogram, I think it would have blocked both of them. But I think they wanted to approach a more safe. They wanted to adopt safer approach because of healthy subjects. So this was quite encouraging. So another trial which says it's very important to be able to block these by infusing a low dose of sodium nitropurisside. This is what they say. So when we administer AKT, maybe we administer fulmazalin, and in order to avoid some side effects. So their mentality was different from ours when it comes to schizophrenia. So the proof of concept, they did it only in the anesthetics domain. So what they said was they defined the mechanism with blocking the entry of calcium into glutamate receptor.
Arka arkaya.
Then there came 3 trials in a row, and one of them was from London, James Stone et al. In 2016. It was one proof of concept. It was published in Psychomedicine Journal. Negative study. First and foremost, they checked the special working memory because it was proof of concept. Then they checked out secondary outcome, that was PANS, psychotic symptoms. And in the studies, sodium nitropurisside psychotic effect has not been observed clearly. And we evaluated the study. The patients enrolled into the study had not been with acute psychotic. They were chronic psychotic patients, and they were also resistant against chlorozepine. And this is from China, another negative study. We saw the same scene. There were no side effects. However, it was administered to chronic psychotic patients, and we didn't see any effects as well. Last but not least, in Java, this is a Harvard study. It's an outpatient study, again a negative one, and it was not with acute psychotic seizures. Patients were outpatients, were given clozapine. Most of them are refractory patients, and there were no side effects, but there were no effects as well. And we checked that certain methodological works. I think SNP was also photosensitive molecule, as you know. I think they could not make such a mistake in Harvard. There mustn't be an inactivity problem. It should be in a dark room. Why did we find out a difference? I think here you can see the result. These are the patients. This is at the last stage. If you were to make staging, you would say last stage was 4. But in our trial, patients were at the 0.5 or 1 level. It was a difference. So what should we do for the future? Right now, schizophrenia needs staging. Definitely, we need to carry out staging works. We need to be talking about patients in this way. Stage 1, stage 2, stage 3, stage 4. So each and every stage should carry out certain meanings so that we can prescribe our treatments appropriately. If SMP is going to be administered, then patients should have acute psychotic episodes. Because acute one is more different than the chronic one, but it must be the earliest stage because it is accompanied with glutamate psychosis. We have to know SMP very well. Sometimes we might need to increase the dosage. If in the stage 4, for instance, we might have to increase the dosage. We should be administering it once in 2 hours. I think it is not finished yet, but if JAMA negative is valid, then for the future stages, I mean, in terms of financing, it is a bit challenging, yes. If you still feel energetic, we can talk about ketamine, or should we proceed with questions or with the presentation? Any questions from the audience? Can you please pass the microphone? Otherwise, interpreters will not be interpreting the speaker. Unfortunately, it is not audible. And the mic is not on. Now I think you can hear me. So you said that acute psychotic episodes. Yes, it is a very nice thought if you apply SNP to these patients, but I mean, how is it possible to apply SNP in an IV way to these patients for a prolonged time? How did you manage that? So acute psychotic episode, when you look at it in neurochemistry or psychopathology, you will see big differences from chronic psychosis. So when there is chronic psychosis, from that time onwards, neurochemistry of the patient and the neurons and also the brain atrophy are included. That's why pharmacology is not very effective, but I don't know whether it is going to be effective if it is given in higher dosages. But I think these two are very different. Patients with acute episodes, for instance, they are started with antipsychotic dose, but it is the half of the maintenance dosage. We do not continue in the same manner, otherwise there is dyskinesia or problems. We have to carry out more researches. About nitrite oxide, I think it is also called as NMD enhancer. I want to ask you a question. If it is applied with higher dosage, will it trigger NMDA-related toxicity? And after animal trials with respect to schizophrenia, dyskinesia or neuroglyndolin genetic responses are available or not? Thank you very much for reminding it to me. In the SNP, there is arsenic. Are there any side effects of arsenic? Will it create accumulation or create any problems? For that reason, it is at low levels. Beta blockers suppress the SNPs because there is accumulation of this substance. Because once they start, they give it 3 days or months. That's why it is accumulated. But the animal trials issued, those experiments are very complex because we need to know pre-pulse inhibition and non-pharmacological experiments. But I think this is just the start. I mean, if you have 25 years, you should just start doing it that way, yes. Can we proceed with my presentation? Okay, let's talk about ketamine very fast because I see you feel a bit hypoglycemic, so let me just skip that. As we mentioned ketamine, there is ketamine, phencyclidine, MKNT1, and NMDA receptor antagonists. And ketamine has been used for the schizophrenia by some people, but I would like to show you one thing. In the antidepressant world, in the last 5 decades, I think this is the most important invention up until now. Dost knows better than me because there is very exciting news in the United States. There is great developments. So from study, these are the treatment-resistant depression patients. Unfortunately, about 35% of the patients are treatment-resistant depression patients, and we give bilateral ECT and they are not responding to that. They are actually ultra-resistant depressed patients. Our assistants told us that there is TRD right now, there is UTRD, and there is, according to our assistants, there is UUTRD, ultra TRD. So it shows actually the importance of staging. I think this is very crucial. Unfortunately, we don't have this option for our treatments. Why TRD is difficult? Because it is like schizophrenia. Depression is not homogenic. It is heterogeneous, and it is used. This is 0.28 pooled interclass kappa. And even qualified psychiatrists do not recognize depression. The old psychiatrists were able to recognize it, but there are also comorbidities, and there is also high placebo rates, unfortunately. And many pharmaceutical companies gave up because there are no markers. And Dr. Taminga already mentioned that. They just let us, that's it. And they are now directed themselves for working on diabetes because it is very difficult. We don't have any markers. This is from Canada, Jacobson et al., 2015. This is a new antidepressant. You can see this is placebo effect, and MADRS is used as an index. However, Edmonton example, when you administer ketamine, 1 hour, 2 hours, 3 hours, but it is not valid for everyone. It is not a solution to every problem, but in certain patients, given in BDI, from 38 down to 25, there is a huge decrease, and this is a great development for the depression because it eliminates depression syndromes. And from Yale, Duman and Agajagyan published their article in the last 5 decades. According to them, ketamine has become the biggest invention for the depression treatment because it has a very speedy and quick effect for the treatment resistant patients. And there are 4 swimming tests, and also routes have been used for depression. And in other trials, antidepressant effect was received from ketamine, and also in the animal experts, Dr. Tami showed us that in the hippocampus they triggered neurogenesis, so they actually regenerate the hippocampus. And this is the story behind that. Again, from Yale, John Crystal and his group carried out a study in the year 2000. In Biopsychology it was published, and after that you see right now many people followed them in their studies, bipolar depression and in the refractory bipolar depression, in the suicidal ideations, for instance. But if you look at the dates in Russia, as of 1980s, ketamine has been known very well. And ketamine has been used as an adjunctive treatment option for alcohol and heroin addicts. This is not something new. Maybe it is just Russian literature. That's why it was not put into the mainstream literature. But this is important. That's why right now we are just looking at the very previous literatures. Okay, NMDA receptor antagonist. Ketamine is an NMDA receptor antagonist. I've told this for 30 or 40 times maybe. It is noted it affects within 5 minutes, and half-life is 1 to 2 hours. And this is not a joke. Our veterinary friends use this as horse anesthetics because there are some problematic horses, and before treating them, ketamine is mainly used. Illegally on the raves, in parties, yes, it might be used. So here you can see its effects mechanism. There is ketamine binding site in the glutamate receptor. When it is bound to glutamate, like phencyclidine, MKTO1, it blocks calcium entering into the receptor, and then presynaptically and postsynaptically certain changes do occur on the mainstream of these senses. Okay, what is that? So dose makes the poison. This is a proverb, okay? Yes. Dose makes the poison. We know it's from lithium, right? Because if you use lithium appropriately, it's a lifesaver. But sometimes we see that in some tragic cases, if they are overdosed, then patients lose their lives, because if it is overdose, it is too toxic. And ketamine is the same. If it is between 0.5 and 1 milligram, it is antidepressant. In parties, in discotheques, in clubs, in raves, if they give it a bit higher. So those criminal guys, those drug dealers, know how ketamine works, right? So because if they give 0.5 milligram, nobody wants to buy it. So it is in between 0.5 to 1 milligram, so that they can be defined as good drug dealers. People can get psychedelic and disassociative. If you look at YouTube in this kind of videos, you will see the results, details. And if it is, about that, it is at the anesthetic range. If it is about 4.5 milligrams, then it might kill you. You need to know the dosages. And each and every dose addition, it adds different neurochemistry. Maybe at the very first stages, it affects NMDA, but in the higher dosages, it affects glutamates. Kapoor had a publication in the journal. He said that ketamine is not related to NMDA because he thinks that everything is related to dopamine and the schizophrenia in the bipolar patients. Ketamine or other NMDA antagonists being a trigger for psychosis is that if they are given at higher dosages, they can increase limbic system activation. And this is very complex. We don't know it. Actually, we don't know how it is activated, and hypotheses are very entertaining and exciting. When you block NMDA, AMPA becomes an agonist. This is the real effect. AMPAs potentiating agents. AMPAs being an agonist. Faizi knows that better than me. There is mTOR system as well. This is very complicated. It is affected by lithium. I don't know whether it is here or it affects BDNF. It increases BDNF very quickly, and it might end up with neurogenesis. So there are great publications. We are very excited because seeing such a publication in Nature. I mean, even Nature published NMDA and ketamine action mechanism. Yes, this is something great. Up until now, everything has been okay. But in the last year, in 2018, in Stanford, there was another article published. They said that this is just a story. This is just the story, that's it. This is not a thing but a story. In American Journal of Psychiatry, they carried out another study, and patients, by the way, they stopped the trial earlier. They enrolled depressed patients and administered ketamine to them, and on the other arm, placebo was given, and other groups were given naltrexone. You know naltrexone, right? An opioid receptor antagonist. So what happened after that? Naltrexone is very selective. A normal person, there is no effect of naltrexone. I mean, I can easily swallow a naltrexone, there is no effect. But if a person abuses opioids, if opioid system of people are changed, then it can create different results. So what happens after that? They say that yes, after this publication, there was a huge anxiety and concern in the sector. Naltrexone blocks antidepressant effects of ketamine in depressed patients, but it does not touch its dissociative effects of it. Patients get dissociative because this is a psychotic scene, yes, they get psychotic, dissociative, but their depression effects are eliminated. So they are impressed a lot, that's why they stopped the trial earlier than expected. And then they said that yes, everything is great, but whether this opioid system can play a predominating role or not. And this is the importance of that. Right now, Johnson in the last month was approved by FDA because in Canada, opioid abuse is a great crisis. So they are wondering whether it's going to start another ketamine-related crisis. I will be touching upon that later on. When you look at its effects at the molecular level, it is very exciting. Here you can see saying is given, but when it is given with ketamine, synaptic dendrites are increased. So actually, it refreshes the brain. I mean, I got really impressed and I wanted to buy some ketamine so that my brain cells got refreshed, all the synaptic dendrites numbers could increase. But this is not that clear actually. After that, there comes another exciting development. I want to skip it very fast. This is the meta-analysis. In each and every trial, ketamine was proven with its antidepressant effect. And in this psychiatry, the most effective treatment is electroconvulsive treatment. Its effect size is 0.8, 0.7, 0.8, right? And clozapine effect size in schizophrenia is 0.4, 0.5. Olanzapine's effect size is 0.2. But after seeing that, it says 1.3. Ketamine's effect size is 1.3 in bipolar depression, and in the MDD, it is 1.3. Seeing such a figure changed all statistics. When you look at the response rate, it is between 40 to 90%. Well, what did we do? Let me again skip it very fast. We tried to answer certain questions. Because we have a ketamine clinic approved by the Ministry of Health. So what are our activities in our clinic? We wanted to see the outcomes of depression rating scales with a course 6 treatments of 0.5 IV ketamine infused over 40 minutes for URD patients in a clinical setting. So we wanted to see the outcomes. And it was a naturalistic study. We wanted to see the same results. We wondered whether we could see the same results or not, and it was published on Journal of Psychopharmacology. We didn't need anesthesiology. Psychiatrists and our nurses, they should be at the hospital. So in whole, we gave 6 IV sessions, and as a protocol, we selected ultra-resistant depression. This is inclusion criteria. You can see major depressive episode, unipolar or bipolar. There must be at least 5 antidepressants of the patient. In addition to that, there must be ECT. So 90% of the patients were not responsive to ECT, or they were not suitable for ECT, and acute suicidal patients were also included to our trial. As an exclusion criteria, you can see active psychotic patients. They had substance abuse and depression, and no, we excluded them. We didn't give ketamine to those patient groups in our clinic. And we collected a lot of data, as you can see, family trees, substance use, and suicide history and rating scale. I want to show this to you. And this is the analysis. Logistic regression analysis and response rates were assessed. So what was the reason for that? We wanted to see 50 patients results when they come with some naturalistic symptoms. And we also wanted to understand whether there comes any predictive result. ECT patients, 96%, and 8 antidepressants for nighttime augmentation was tried. Approximately 65% of them had also anxiety disorder. And you can also see their mean age, it is 51 to 52. Remission rate and response rate. Compared to literature, it is a bit lower. We haven't seen any antidepressant that we saw. It is 44%, but it is again great because this is ultra resistant depression, and remission rate is very low. It is 16%, but compared to literature, this is a bit lower because it is between 40% to 60%, but here it's a bit lower. And we also conducted a logistic regression analysis. We checked our data and tried to figure out which patients must be given ketamine. Anhedonic patients and bipolar depressive patients, ketamine was found to be more effective. Especially anhedonic patients can get greater results if they are given ketamine. Okay, I'll skip this because we don't have time. When we look at side effects, it is from the textbook. It is definitely the same with the textbook side effects. Dissociative patients, 70% of them showed dissociative side effects, and up to 55% of them had dizziness, and also disequilibrium occurred, but they are all temporary. In certain patients, blood pressure decreased, then it's increased, but we didn't experience a very severe problem. But after given IV ketamine, they couldn't drive their cars for 24 hours, and they must be accompanied to their houses with their friends or anyone. Anhedonia is very important because, yes, it is very crucial. It must be reviewed. And the reason for that, it has many negative prognostic factors, and it is a risk factor for suicide, and it has a mechanism. Thus, by the way, I'm about to finish my presentation. So, which patients must be given IV ketamine? Okay, let me skip that. In the United States, you know this better than me. Up until a very recent time, you can see on this map, I took it from Clinical Trial Network. Ketamine has Facebook, there is Advocacy Network, there is $400, $800 per infusion in each and every private clinics, but then big news came. Intranasal Johnson, intranasal esketamine, which is the more effective one because it can penetrate into the brain more quickly. It was approved by FDA. It is a nasal spray. It's a spray water. But there is a REMS system, risk evaluation and mitigation strategy. So it is under scrutiny. Yes, it has been approved, but doctors and the hospitals that are going to utilize it, maybe those who will clarify it, should control it. It is a responsibility. They should not create further opioid crisis. It is not like prescribing the ketamine and letting patients go away. There must be responsibility on the physicians and hospitals. Here you see ketamine-induced ulcerative cystitis, and here you see they have urination with blood. This is all I would like to say. Thank you very much.